So, good morning. First of all, I would like to congratulate Govil sir for arranging such a uh, refreshment course which is very useful for all of us. And this is the morbid obesity. This is a matter of concern for most of us. Recently, we are having 3 or 4 patients in our ICU, which covers almost all aspects which I am going to discuss, including one of the patient is a COVID patient, another MI with multi-organ and coagulopathy. One patient was OSA and respiratory failure, which was managed on an IV. So it's a real concern. Epidemiology and WHO says that every fifth Indian is obese. So, as I explained that in our ICU also we are having recently few of the patients. So, this is on the basis of BMI. We classify the patients. So, of course, the patient who are having BMI more than 40 comes in the category of morbid obesity. So, why actually these patients comes to ICU? So, apart from the routine indications like a patient is having sepsis, respiratory failure, other patient comes with the metabolic complications, comorbidities, and they also come for the COVID, ARDS, and bariatric surgery. Morbid obesity in medical ICU, the mortality is high. However, there is a paradox also. So I will discuss in next. Prolonged mechanical ventilation and extended weaning is the challenge. Multi-organ failure remains the best predictor for mortality. And the scoring system which we are routinely using, they're insufficient because they do not consider BMI, take BMI into consideration. Synergistic effect of obesity in severe illnesses, that is the obesity unless this is a double hit kind of things. Insulin resistance, increased sympathetic nervous system activity, increased catecholamines, increased inflammatory cytokinins, IL-6 and TNF-alpha, lipolysis, free fatty acids, muscle breakdown and hyperglycemia. So this is the slide which is little busy but expresses a lot. Neurologically altered respiratory drag, pulmonology in respiratory, the decreased compliance, FRC is decreased, de-recruitment, VQ mismatch, work of breathing is high, and intrinsic PEEP high. Looking at the neck and pharyngeal adiposity, that poses problem with difficult bag and mask ventilation, difficult intubation and tracheostomy challenges. Cardiac, so left ventricular hypertrophy, diastolic, systolic dysfunction, right ventricular mass dysfunction, circulating blood volume is high, abdominal pressures are high, so that lead to reduction in the venous return. Renal, suprarenal GFR is there, chronic kidney disease along with the renal congestion because of the high intra-abdominal pressures. Hematologically, the venous thromboembolism, difficult vascular access, dermatological pressure injuries, pressure ulcers, and perspiration that causes the infections, fungal infection between the creases. Gastrointestinal, the fatty liver disease, endocrine, insulin resistance, and hyperlipidemia. Musculoskeletal work of movement is more difficult, mobilizations and frailty, along with the degenerative joint diseases are more commonly seen in the subset of the patients. Pharmacokinetics, the volume of distribution is high and elimination T-half. So there is a T-half is high, and the hydrophobic drugs, particularly for the hydrophobic drugs. This is the same, the mood disorders, social stigma, the same thing we have. This is all about the management consideration in the different scenarios, which we will learn in upcoming slides. So intubation, ARDS, refractory hypoxia, OHS and respiratory failure, extubation, hypotension, pressure ulcers. So these are the all challenges which I'm sure most of us has faced in while we are taking care of these patients, such patients, subsets of the patients in our ICU. Airway securing in emergency, so super morbid, so those who are having the BMI more than 50 or 60, the short and thick neck, increased neck circumferences, redundant soft tissue in the oropharynx, limited mouth opening, short thyromental distances, short sternomental distances, Mallampati grade 4, macroglycia, OSA, and increased BMI. So this all poses a lot of challenges in airway management. This is the upper airway related. So functional residual capacity is low, sedatives, relaxes, and they are usually more sensitive. So the muscles gets relaxes, hypotension happens earlier, loss of arousable defense mechanism, obesity, so pharyngeal soft tissue, pharyngeal anatomical imbalance, dilators, activities there. So lung volume hypothesis, so there is a more visceral fat and lung volume is low and pharyngeal wall gets collapsed. So this poses the additional upper airway challenge. BiPAP has been used for the oxygenation on the rapid sequence induction when the conventional method of pre-oxygenation you are not able to achieve the saturation more than 90, then it should be used and should be used earlier. If such methods are not successful, then we should think of emergent tracheostomy also. Longer tubes, sharper angles, and that is the long flange tubes are the choice. Higher complications rate have also been reported in the tube placement, whether you are doing surgical or you are doing percutaneous. Airway complications like difficult laryngoscopy is not more prevalent in obese patients. This is right, and the high BMI is not an independent risk factor. However, when there is a neck circumference is more than 40, there is an associated risk of ventilation and intubation is more, laryngoscopy difficult, and more than 60, it is more problematic. Also associated with Mallampati grade 3, the laryngoscopy along with the OSA is difficult. So intraoperatively in anesthetic room, we have patient position important, video laryngoscopy, glide scope, bronchoscope and airway adjunct should be kept ready. Head elevated laryngoscopic position should be followed. It helps us in achieving more than 25% better pre-oxygenation. As there is a rapid desaturation, so it gives us a little more time. This is the head up position and ramp position also. So airway management most of the time is emergency, and the person who is intubating or handling airway must be most experienced person available at that time. Airway equipment should be well arranged and ramp position should be considered. Why these challenges are the difficult of the bag and mask ventilation is the one concern. Second is poor view or direct laryngoscopy. Short laryngoscopic blade handle should be used and laryngoscopic handle should be used. Rapid desaturation. So these patients don't give you much time. So you should be prepared accordingly. They desaturate very rapidly. Assistant should hold back breath and apply the required pressure as well, so that the person who is intubating should get the appropriate place. This is you can see the two ramp and non-ramp position. The ramp position is the preferred and it really helps while you are handling the airway. There are some ready-made rampers also available, but we are using what we have the conventional one. Airway emergency, the role of supraglottic airway device, role of rapid sequence induction and role of video laryngoscope. If you are in the situation like cannot intubate, cannot ventilate, so first thing is very important, you should not waste time, you should go quickly for the surgical airway. For that you should localize, before you are even handling the airway, you should localize the cricoid membrane beforehand. So whenever patient is in your ICU, you should localize it, and then you can go for the needle cricotherotomy or the tracheostomy. Sedation in the morbidly obese patient, altered pharmacokinetics, and extremely sensitive to the sedative. So they develop hypotension, they desaturate very rapidly. So the choices are the short-acting agents like propofol, dexmedetomidine, and remifentanil. Mechanical ventilation, so volume control and pressure control, whatever you are more comfortable with. Tidal volume 6 to 8. Mani sir has already explained that it should be 4 to 6, but in this particular subset, you need a little high, and that is with the ideal body weight. Respiratory rate should be 12 to 14. Reason being to avoid the hyperventilation. Here, the plateau pressure you will accept a little bit high. In place of 30, you can accept till 35. Lung recruitment strategy should be there, and the anti-tunnel position should be kept. And why this happens that a patient gets desaturated quickly because of the respiratory muscle fatigue. Intra-abdominal pressures are also high in these patients. High transpulmonary pressures, higher P-flat is acceptable, and PEEP should be best optimized. Weaning of the ventilation is again a challenge. Weaning protocol should be followed. Wherever required, NIV should be used earliest, early tracheostomy. So tracheostomy will help you in decreasing the need of sedation, reducing the work of breathing, and early ambulation. Long flange tracheostomy tube should be chosen. So regarding the monitoring, so BP cuff, most of the time BP cuff are inadequate and inappropriate. So that leads to inappropriate monitoring. So cuff length should be more than 88% circumference, and width should be more than 50%, which is the more than usual. RTL line should be assessed earlier. Ultrasound guided access should be there. PIC line also should be considered earlier, because these patients surely they have a difficult IV access, and they will require it for a longer time for sampling, for your IV injections and monitoring. And femoral should be avoided because of the infective and thrombosis issues. Hemodynamic monitoring and IV monitoring is unpredictable. Even if you are using appropriately sized cuff, even then these are unpredictable. Hemodynamic parameters are adjusted to body surface area. Potential variation to calculate the index value depend upon the weight chosen, that is actual, adjusted, or the ideal. In ideal body weight is not optimal for the because the oxygenation demand and the cardiac output are higher for these patients. Vascular accesses, obscured landmark, so it is most of the time it is difficult. Depth of the insertion is variable. Distorted angle of the insertion, catheter related infections, because if you are having multiple punctures, then the chances of infections are also high. So use ultrasound as in most of the cases. Central venous line, time consuming and challenging. Longer needles are required. Vigilance of the infection and the phlebitis, thrombosis should be kept. These patients don't tolerate reverse Thunderbird position, so that is also one of the challenge. And X-rays are also not very accurate for localizations. These are the different side of the cuffs. So the other different situations which you see in the respiratory is sleep apnea, when your airflow is there is no airflow for more than 10 seconds. Obstructive sleep apnea effort but no airflow due to the upper airway obstruction. So here the main pathophysiology is obstruction, whereas the central apnea, there is we are not getting the signals. So patient is not initiating breathe. Overlay syndrome, the chronic obstructive pulmonary disease with coexisting OSA, mixed apnea, element of obstructive and element of central apnea together. Hypopnea, decrease in the breathing, but still airflow is maintained. OSA, the definition of, so obesity here, the BMI more than 30, PaCO2 more than 45, sleep disorders of the breathing are there. Overlap syndrome, COPD patients with the OSA. So patients are typically obese, smoker, moderate to severe nocturnal oxyhemoglobin desaturation. Worst event occur during the REM phase of the sleep. Worst prognosis, ABG, OSA without COPD. Diagnose OSA complications, COPD patient with nightly arousable dyspnea, desaturation and resistance to oxygen, supplemental oxygen. Patient of OSA can present with chronic hypoxia and periodic desaturation leading to the chronic polycythemia, chronic hypercapnia leading to the pulmonary hypertension. For pulmonary, right ventricular failure and systemic hypotension and arrhythmias. Sedation narcotics, we have discussed this earlier. Short acting should be there, and you should be prepared for earlier desaturation and worsening. Oxygenation level may take months time or the longer time, so you have to accept the lower saturation while you are considering for extubation, and straightway go for the NIV. Bedside diagnosis of OSA, so patient is snoring, tiredness is there, observed apnea, you can see apnea on bedside, pressures, and BMI is more than 35, age more than 50, neck circumference more than 42, gender is male in these patients, mostly. The respiratory efforts, so work of breathing is high, abnormal chest wall elasticity, chest wall resistance is high, airway resistance high, abnormal diaphragmatic position because of the abdominal pressures, and upper airway resistance, CO2 protection is also high. These are the cardiovascular effects. Total blood volume is high, resistance, cardiac output, stroke volume high, heart rate is unchanged, impaired left ventricular contractility, left ventricular dilatation and hypertrophy. Left ventricular filling pressures are high and fluid overload is poorly tolerated in these patients. Increased ICU morbidity. There is an increase in ICU morbidity, but as per paradox, there is a reduced mortality. So the main burden, main challenge for the ICU professional is morbidity. Increased chances of aspiration pneumonia because of gastric fluid volumes are high, intra-abdominal pressures are high, and these the pH and tones of the lower esophageal sphincter is low, hiatal hernia is associated. Drug dose effects are altered distribution, metabolism, protein binding, and clearance due to the physiological effects. Loading doses, hydrophilic, either no changes, or the hydrophilic or hydrophobic, there is an increase in dose for the loading about 40%. Lipophilic should be calculated on the basis of actual body weight because these gets deposited in your adipose tissues. Maintenance dose, base of the clearance, it is on the basis of the clearance data, little data is available, antibiotic changes as per classes, so and a maximum prescribed dose can be used in these patients. Nutrition and dosing anesthesia, so increase in the volume of distribution for the particularly lipophilic drugs and increase in clearance for the hydrophilic drugs. So adjusted body weight is calculated and checked with the pharmacist. Antibiotics should be adjusted as per the ideal body weight. Anticoagulations, as per BMI, for the higher BMI, we use 60 milligram BD of enoxaparin and 40 milligram BD for this less than 40 BMI. Minimum narcotics, benzodiazepines, propofol, as these all are lipophilics. Surgical challenges are the anesthetic challenges, closed space, difficult feed, obscure fat planes, positioning, and diagnostics. In bariatric surgery, for the young patients, this is elective, often associated with comorbidities like diabetes, blood pressure, hypertension, OSA. So these all get benefited by this. But at the same time, we have to see the risk factors are like wound adhesions, leak, bleeding, sepsis, venous thromboembolism, intra and post-operative desaturations, atelectasis should be kept in mind. Anastomotic leak is a common phenomenon in these and should be kept in mind, like incidence is 0.5 to 2.5, abdominal pain, left shoulder pain, signs of the impending doom, pulse rate is high, respiratory rate 24, saturation less than 92, sudden respiratory decompensation, sudden pleural effusion, and classic peritoneal signs may not be present. Failure to recognize this deterioration or may lead to even death. CT scans may not be possible in such scenarios. So whenever there is doubt regarding anastomotic leak or you are suspecting, you should do a diagnostic laparoscopy. Rhabdomyolysis is also a known entity and creates a lot of problem, like it is post-op, prolonged surgery because of the improper padding, ischemia is there, severe pain in hip, gluteal and the lumbar, shoulder, and patient may present with the oliguria, not responding to fluid challenges, severe compartmental syndrome, and CPK may be high in thousands. So prevention, again taking care of all these like padding, positioning, and keeping in mind that to minimize the operative timings and maintaining the high index of suspicion in most of the post-operative patients. Abdominal compartment syndrome. Again, so these are the obese patients have the higher intra-abdominal pressures as compared to the non-obese. The incidence of clinically significant abdominal compartment syndrome in critically ill obese patient is unknown. And monitoring, we should start the intra-abdominal pressure monitoring early. Whenever your patient is having tachycardia, tachypnea, and desaturations, always think of atelectasis. These are the imaging diagnostic related challenges. If you are applying your ECG leads, you may not be able to apply it right side because of the landmarks. So your ECG findings may not be appropriate. You are not able to put a echo, so proper images may not be there. Inadequate soft tissue penetration, so radiograph, whatever you are getting on bedside may not be appropriate. There are limitations of the CT scans also. So load limit is like 160 kg, and if you are getting patients like 200 kg or like that, so you may even have to consider the veterinary CT equipments. So far, however, I have not considered anything like this kind of equipment. Feeding, you should take care of the feeding and nutrition. Your recommendation 20 to 30 kilocalories per kg per day, and enough proteins like more than 2 grams per kg of per ideal weight should be given per day. Nursing care is also equally important, and you should anti-tendinous position, prevent the bad sores, preventing the infections, preventing changes in the posture, early ambulation, perineal hygiene, fungal infections, changing the linings and sensitivity trainings, of course including all fast basic nursing. So this is your transportation is not that easy in these patients. So these are certain equipments available, so you can commercially available. Ultrasound, so role of ultrasound for vascular access, diagnosing the complications, pain relief, and diagnosing the pneumothorax. So we have recently had the ultrasound course here also. Organizations of logistics like keeping such kind of the patient, if having a dedicated floor or dedicated team for that, like furnitures, transport system, other logistics, other facility, OT, casualty, and radiology should be considered. So obesity paradox. Morbidity is high in these patients, everything, but the mortality is not that bad. So that is the outcome ICU. Reason being, the scoring system we are using, we are not considering BMI in it. Obesity is not captured in it. Conflicting results, and this is for just. So you can see this is the adipokines leptin is the chronic inflammation is more, and acute inflammatory is reduced. So if you see that a mechanism is the TNF alpha inflammatory markers here are high, insulin resistance and vascular dysfunction is leading to type 2 diabetes, cardiovascular complications. So morbidities are being badly affected because of the obesity. Similarly, in acute inflammation, the immunity is compromised, so there is susceptibility of for the infections. However, because of the physiological reverse cholesterol reserves, cholesterol, lipids, neutrophilic function, endotoxin binding, adrenal steroid synthesis, so mortality is reduced mortality is observed. So this is seen. So the need of time is the training, teaching, bariatric super specialty, optimization of comorbidities, sensitivity training, laying out the clear protocols, training of the training of users of ultrasound, multidisciplinary team approach. So with these key points, I would conclude my talk. Obesity poses the unique challenges in the ICU team, including all professionals like physiotherapists, nutritionists, and we as intensivists. Important changes of cardiovascular, pulmonary, and immunological physiology predisposes such patients to respiratory failure, thromboembolic disease, abdominal compartment syndrome, and aspiration. Special attention is required when performing the routine ICU procedures. Limitation of testing capabilities, clinical suspicion when making the therapeutic decisions, uncertainties regarding the drug metabolism, pharmacokinetics, and nutrition needs, challenges, and bedside nursing care. Dedicated research is much needed in obese patients to allow the formulation of evidence-based guidelines that would further enhance the delivery of ICU care for this challenging population. Thank you. So this is. Questions. Thank you.
Thank you, sir. Thank you, sir.